and video. So we'll go ahead and get started. Welcome everyone. Thank you for joining us for this Ask the Ataxia expert session. I'm Lori Sjogren, Community Program and Services Director for the National Ataxia Foundation, and I'll be assisting with today's session. We have a few of the usual housekeeping notes just to go over before we get started. First, all attendees are muted, and we ask that you please keep yourself muted throughout today's session to reduce any background noise. Also, as many of you know, transmission interruptions can occur. So if you do get disconnected, please try logging in again. And we apologize for any transmission disruptions that may occur on our end. Also wanted to mention to everyone that closed captioning is available for today's session. And if you want to enable the closed captioning feature, you just click on the closed captioning button that's found on the bottom of your screen and select the show subtitles option. One final note, questions for our speaker can be typed in the chat, and that's found at the bottom of your screen as well. Questions can be submitted in the chat throughout the session, and we'll try to answer as many of your questions as time allows. Now I'm excited to introduce our today's ataxia expert, who's the well-known Dr. Christopher Gomez. Among many other accomplishments in the ataxia field, Dr. Gomez established the University of Chicago Ataxia Center as a specialty clinic and research center devoted to the diagnosis, treatment, and management of ataxias, and as focal points for translational and clinical research. Welcome, Dr. Gomez.
Thanks very much, Lori, and for organizing this, and thanks for everybody else who is attending. This is a really wonderful venue, and I've take a look at a couple of my friends Ask the Expert YouTubes.
I can't get sound on my audio.
We can certainly hear her sound. I want to let you know that I'm actually hiding in a bedroom while people are cleaning my carpets at my house, making a lot of noise. So I will probably, once I hear them leave, I will probably escape out to the other part of the room. I've gone over there are lots of questions that were submitted, and I'm eager to get on and talk about them. So if you don't mind, I think I'll just do them in order for about 20 of them. I'll try to make short answers because there are 45 questions or so. And so maybe about 20 in there. Lori will maybe interrupt me and we'll try some chat questions instead. Hello to everybody, many familiar faces, and I'm glad to see you all. Some of my, I just sent out a couple notices to some other of my patients and friends to log on. So I'm just going to go from top to bottom and not discriminate in any way for what these questions are focusing on, okay? All right, so the first question is about something I spoke about a lot of years ago at the NAF meeting. What are the pros and cons of a baclofen pump? How long should I expect the pump to be effective? How often are there complications like infections, et cetera? And how often did paralysis happen with the trial injection? And then the person says, I have SPG7, and would that help me? Okay, so the baclofen pump is an invasive procedure, which is a symptomatic therapy. In other words, it does not get rid of any parts of the disease. It's focused on treating the symptom of spasticity. The spasticity is a part of neurological disease in which the legs are stiff and unable to control due to a pathway called the cortical spinal tract being involved. It goes all the way down your spine. You see that kind of spasticity in cases like spinal cord injury or a stroke where the arm is very stiff on one side from spasticity. And people use the medication baclofen to lessen that spasticity and make the limb or limbs more movable by relaxing them. And it's tried primarily with oral baclofen, but some people who benefit a lot from the oral baclofen, but get symptoms of sedation, side effects of sedation, they recommend, you can recommend a baclofen pump. And that can squirt it into your spinal fluid safely, with the requirement of having to manage that very carefully with controlling it with the computer and re-injecting more baclofen inside the reservoir. So baclofen pumps are a potential solution for anybody's ataxia who also has spasticity. If you don't have spasticity, it's not going to fix it. And if you have spasticity, it's going to lessen it, but not eliminate it. You start out by assessing this by finding out that they benefit from oral baclofen, but get into too many side effects. And you find out whether it's potentially workable by a trial injection, where a very small amount is injected into the spinal fluid, and then you assess how much better the patient is with one single injection. There are significant complications. I have only a couple of patients who have baclofen pumps, because it's quite an effort to be sure it's managed properly. But one who I'll never forget had very severe SCA3, and it was treating not just her spasticity, but her dystonia. And she had severe pain from her dystonia, and she had multiple infections complicating this. And yet she swore to me, this is only one case, she swore to me that still was far outweighed the fact that she loved the fact that her pain was lessened by the baclofen pump. Because in spite of the infections, they had to remove the pump and reinserted a couple of times, she still benefited. But it's an effort to get it. And I actually have a number of patients who have it, and they benefit from it. I think that's enough for that one. Okay, it could potentially help somebody with SPG7 because that's a spastic ataxia. Okay, the next question is entirely different. So much good news on CRISPR in recent months, and ASO has reported that it's able to mitigate the disease in SCA3 back in 2018. Also AAV from Unicure has announced its research pipeline for SCA3 since 2019. Okay, that's fortunately not a question. It's just a statement. So I'm going to say yes, that is true. I want to reserve judgment on CRISPR. Remember that CRISPR is a therapy, an approach that's targeted towards correcting the gene in the cells that are making the abnormal gene. And so that's why in things like sickle cell, or in what's that disease? In familial amyloidosis, you can correct the gene that's making a bad protein in the liver or in the blood, in the bone marrow, and potentially stop the production of a bad gene. The problem with us is we have to do that correction in the cerebellum to fix ataxias, and we have to do it early because we don't want to do it in cells that have already died from the abnormal gene. So it must be, if it's going to be ever happening, it's going to have to be instituted very early, and we have to do this in cells that are very precious to us. That is our brain cells. So I want to reserve judgment on how valuable that will ever be to try to correct abnormal genes in brain cells. I think that's an effort. It's happened in animals, but I worry that I don't want to be put too much hope on that till it actually starts to happen. Okay. Next, perhaps Dr. Gomez could comment. Okay, this is actually the same thing. Comment on genetic therapy. Is it realistic to expect intervention? Can you perhaps comment on what has been preventing these techniques from clinical stage to human trials? And though I recall that previous session, Schmaman mentioned that there will be several ASO trials coming soon. Okay, yes. Okay, so the ASO trials that we know of so far, we can list on one hand. or studies. Let's go from the super successful to the questionable. The super successful was using an ASO to correct a silenced gene in a childhood fatal illness called spinal muscular atrophy. A different gene, a different disease, but a fatal childhood illness. And that ASO was a special sequence that found the silenced gene in the SMN gene and fixed it. And these children, due to this therapy, are now living beyond their death sentence of 2 years of age because of approaches like this. And it's a tremendously successful result. There have been less beneficial effects from things like myotonic dystrophy, but there's been an approach there. And in the world of the degenerative ataxia-like diseases, we have Huntington's. Huntington's disease is a similar disease to the ataxias in that a mutant gene called Huntington has a similar mutation and causes similar but not identical degenerative changes in the brain. And some early successful therapy targeted a Huntington's specific ASO, antisense oligo, to the Huntington's gene. And they had a very clever approach to finding out that they had achieved what we call target engagement. Think of the war in Iraq and whether they were able to hit a target where terrorists were sitting with sensors and radar and the help of drones. Target engagement means they needed to have proof that the ASO, specific for Huntington's, was engaging the Huntington's gene and silencing it. And they did that by measuring the presence of the protein Huntington in the spinal fluid. And patients who have normal people have Huntington's protein in their spinal fluid. And target engagement was proven because the ASO made the Huntington protein go down in the spinal fluid. And that was considered an early success. Now, we all know that therapy, that trial has been stopped, and it's not been released exactly why it was stopped, but there was a very important next step that they had to achieve after they showed target engagement. And that was that by reducing the amount of Huntington's, did that benefit the patient at all? Did that reducing Huntington's protein have a benefit on the patient? And that's the stuff that's hard to prove, both in Huntington's disease and ataxia. And that's part of the reason why things are on hold. You all have heard that researchers, including ourselves, have been able to stop the disease protein in a mouse, in SCA1 mice, and SCA2 mice, SCA3 mice, and SCA6 mice. We've all been able to stop the disease protein using an ASO-like approach or microRNA-like approach. That's gene therapy. And that's a mouse. Now we have to get to knowing whether or not we can prove that in a human. And the effort for that is very complicated. These ataxias are slowly progressive, and we need enough time and enough numbers. We need to know what kind of numbers we need to prove that a therapy is working. And that may be a very large number. How many patients did we need to show that the very simple, logical, straightforward COVID vaccine was working? Anybody know? The first trial was about 40,000 people. That's basically all the ataxia patients in the United States. And that was a yes-no answer. Did you get COVID or did you not get COVID? That's how easy it was to prove that, but they needed 40,000 people. Okay, now for the ataxias, we have many smaller numbers, and we need measurements that prove it's working. And those measurements need to be a combination of a measurement of their coordination, their brain structure, shrinkage or not shrinkage, their brain chemistry, and most importantly, they need to coordinate with what the patients think. Imagine if I were to take a therapy and give it to you guys, 100 of you guys, and come back and tell you that my wearable sensors showed you that you weren't coordinated, that you were not getting uncoordinated anymore, you would easily be able to say, yeah, but I still suck. I'm still really uncoordinated. You didn't help me at all. So we need a therapy that the patients can report back that it is working. It needs to coordinate with patient's experience. And that's the big hurdle that everybody is having in the world of degenerative disease research. Okay, that's 3 questions so far. Okay, a good change up here is question number 4. How common is some form of dizziness, spinning, or vertigo, whatever you call it, in SCA? Is it more common in certain types? Does it affect primarily balance? I always think of it as a common symptom, but it was usually corrected and told that it is not. Okay, I don't know who corrected that person, but let me tell you how it goes. First of all, the term dizziness is a very personal term. Okay, it's hard to get an impression of what a patient means by dizziness. Many patients think that just being unsteady is dizzy. Okay, and I don't mean to correct them when they say that, but I mean to say when I think of that being unsteady, I think of something different than dizziness. Dizziness is a feeling in your head, a feeling that your head is having motion or rotation, or the world around you is having rotation. But a very close cousin to that feeling is very common, which is a feeling of giddiness or just sort of unsteadiness inside your head. And between the true dizziness, which is really vertigo, and this giddiness, I would say it's pretty common. I would say roughly 1 in 10 of patients have this. And it may be more common in some kinds of ataxia. It's more common in SCA6 and SCA3, I would say, and pretty common in MSA-C. So I would say it's pretty common, and I have had variable successes at treating it with various medications that belong to what we call a family of vestibular suppressants. And those are the same kind of medications that are used for car sickness and motion sickness, like meclizine. And there's a whole group of them that we try to carefully use without getting side effects to treat dizziness. Now, I love this part of this question. How does it affect balance? Well, I would say that I have had many examples where a patient had ataxia and had vertigo, and I was at least able to suppress the vertigo with a vestibular medication. And by getting rid of their vertigo, they had better balance. Even though I didn't make their cerebellums any better, I got rid of this spinning feeling, and that was a benefit. So I would say it's a useful success. Let me see. And can seeing a physical vestibular specialist help ataxia? Yes. Part of this vertigo that comes with ataxia has to do with confusion of the system, with this disease process going on, and the brain having a hard time reacting to that. Just like younger kids have more trouble with car sickness than older kids, who are able to train their vestibular system to react better to cues. And so I think ENT therapists, occupational physical therapists who are vestibular specialists, do a lot to train the system to tolerate these missed messages that come from ataxia. So I'm very positive about that. Okay, now here's some good news. I'm going to move to a different room while I pause. Oh no, it's still noisy out there. I'm sorry. I thought I had stopped vacuuming. Okay, next question. Okay, here's a series of questions I don't really understand. Energy production is not very effective in most types of ataxia due to the cell's mitochondria. I don't know where that person got that statement. There's no evidence that I know of for that that's official, and I do research on mitochondria. But one thing is for sure, patients with ataxia definitely have fatigue and lack of energy. And that's not very different from patients with multiple sclerosis or Parkinson's or ALS. Having a neurological disease, in my view, is an energy taxing thing, because a person who has a neurological disease like ataxia has normal nerve cells and has abnormal nerve cells. And the remaining normal nerve cells and circuits are doing an extra amount of work to compensate for the abnormal nerve cells. And therefore, it's exhausting and taxing. So in my clinic, I strongly emphasize a combination of physical therapy and rest. And I tell my patients that's no different than what any football coach or soccer coach tells their players. You guys need to work out and you guys need to rest. And I tell them that patients who are not football players who are not working all year round and come back from off season are a mess because they have not worked out, or if they've not worked out. And so staying in training helps to compensate and cope. And in ataxia and other neurological diseases, staying fit and staying active helps. But both football players, soccer players, and patients need to rest after their workouts. And they need to rest maybe more than other people because they have a compromised nervous system that needs more time to charge their batteries. Okay, I'm going down to question 10. SPG7 is a rare type of ataxia. Is there a more common ataxia or condition that behaves similarly and which is being researched on? Well, SPG7, yes, unfortunately is a rare one. And now I can see that SPG7 person also asked the mitochondrial questions because it's a mitochondrial gene. I would say that the best answer for that is Friedreich's is a much more common recessively inherited ataxia and a much worse, commonly much worse than SPG7, and it's similar in its origins. And so the research is being done on kind of the most common ataxia that may definitely help SPG7. Okay. Can medication for Parkinson's, back to medications, that's a good question. Can medication for Parkinson's disease help? I would say in some cases, yes. And the reason that we give is because all these diseases are not necessarily selective to one part of the brain. And many patients with an SCA, especially SCA2 and 3, may have elements of Parkinson's disease. And if that's the case, medications that replace the missing dopamine that is missing in Parkinson's may help patients with ataxia. And so I often give my patients a trial of the mild Parkinson's medication, amantadine, and I see whether they benefit from that. And if they do, then I keep giving it. And if I sometimes ratchet up and give them the stronger one, which is L-Dopa. And it's very easy to do this safely because these are safe medications with very little side effects. And we can do it as a short-term empiric study. And in about a month or two, we find out whether or not these medications are of any benefit for my patients. Okay. I was diagnosed with late onset. I like questions like this. I was diagnosed with late onset SCA 9 years ago. I'm 77 years of age. Despite 3 genetic tests, no genetic abnormality has been found that could explain my symptoms. I was treated 8 years ago with IVIG. There was no discernible improvement in symptoms. Over the past 9 years, symptoms have progressed. Now I'm on a wheelchair, my speech is affected. Do you have any advice? Okay, so all treatments for ataxia, except for these on the horizon treatments like ASOs, are symptomatic. Baclofen pumps, Parkinson's medications, vertigo medications, they're all symptomatic medications. And anything that this patient who has an unknown ataxia has, they might have symptoms that could be benefit from these symptomatic medications. For example, I treat stiffness with baclofen, vertigo with many vertigo medications. I treat Parkinson's symptoms with Parkinson's medications. I treat burning neuropathy symptoms with gabapentin, et cetera, et cetera. So those are my recommendations for that patient's therapy. And I treat everybody with physical therapy, with physical activity and rest. Now, in terms of genetic tests, that's a moving target. If that patient hasn't had whole exome sequencing, then all genetic tests have not been exhausted. And back in the day, 10 years ago, whole exome sequencing was not very available, and different labs offer different versions of that. And Athena has had kind of a, I'm not going to say a bad word here, have had an erratic way of deploying their genetic testing with cherry picking testing. And so Athena does exome sequencing, but so does many other places, including the University of Chicago. And the problem with being tested 9 years ago is there have been 4 or 5 new genetic ataxias discovered since then. And so they may not have been tested for all of them, even if the whole exome sequencing has been done. Because, for example, Canvas, discovered 3 years ago or 2 years ago, cannot be tested with whole exome sequencing. It can only be tested with one single Canvas gene test. Okay, number 13. And these are taking a long time. If you feel, Lori, if you feel like chiming in at some point, I can give one more answer, and then you can give the chat questions. Could Dr. Gomez outline? What'd you say? Sounds like a plan. Okay. So could Dr. Gomez outline the difference between ataxia and MSAC and the appropriateness of L-DOPA? Yeah, we partially answered this. MSAC is an ataxia. Okay, MSAC is a cerebellar form of a disease called multiple systems atrophy. That disease is named in a very simplistic way by the fact that multiple systems are atrophying at the same time. Now, that's very similar to SCA 1, 2, and 3, which are also multiple systems disorders, but they have a gene. They have a gene test. MSAC is a sporadic disease, non-hereditary in almost all cases. There's no gene associated with it. And so it's defined symptomatically. A patient comes to me with ataxia and 2 of our other additional systems like impotence and bladder problems and blood pressure problems. Then I say, unless you have a positive gene test, you have MSAC. So the positive gene test that could be present, especially with the family history, would be SCA 1, 2, or 3, or Canvas. Canvas can also mimic MSAC. And if they have Parkinson's-like symptoms, then levodopa, carbidopa could work. But I wouldn't spend months wondering that. If it doesn't work relatively rapidly, either amantadine or levodopa, carbidopa, to their symptoms, if they don't feel like they're obviously better, not cured, but symptomatically better, then I wouldn't continue these medications. There's no need to. Okay, I like these frustrated questions because I can really help. For at least 5 years, the neurologic department at the VA, let's not impugn the VA, many tests, has randomly and haphazardly diagnosed my escalating daily occurrences of coordination problems, difficulty walking, search speech as some type of neurological disorder. Yes, ataxia. But unfortunately, without any success or control or cure or even real hope for improvement of any kind, now, to my already state of much confusion, the term ataxia is being bantered about. That's a pejorative term. Can you please help or at least shed some light on what's happening? Perhaps you would even entertain the idea for me to make some direct contact with you. Okay, so 80-year-old person. So there are hundreds of neurologists in the United States, and I'm going to say somewhat overconfidently here, there's only 15 of us who really know what's going on in the United States. The good people who know ataxia. The Parkinson's people know substantially less, although if they studied up on it, they know a lot. But you need to go to an ataxia specialist to really have the best confidence that you've tested everything that can be tested, or at least have your neurologist reach out to one of us and ask us what the approach is. Obviously, someone who has difficulty walking, slurred speech, and imbalance, you guys all know they have ataxia. Whether it's sensory ataxia or vestibular ataxia or cerebellar ataxia, I don't know. I don't know if it's MS causing ataxia. I don't know if it's a brain tumor causing ataxia. Probably a brain scan ruled that out. I don't know if it's SCA causing ataxia, but you all know that they have ataxia. And I would be happy to see that patient either at the University of Chicago or virtually if they're on one of the few states that U of Chicago has a virtual telemedicine arrangement with. I'm happy to see them. Okay. First, realistically, how far away are we from a cure? Secondly, what form will it take? Better vision, improved speech, improved balance. So this is a really great question because it lets me focus on a lot of things. First, these ASOs, these antisense oligos that are silencing these genes in mice and in cells, and these microRNAs and these CRISPR strategies are not curing the disease, okay? They are stopping its progression in mice, okay? To cure the disease would be to fix the gene. And maybe you could say, okay, someday CRISPR will fix the gene. Yes, probably someday CRISPR will fix the gene. I hope it does it in the cells of our nervous system safely and does not harm our cells. But yes, someday CRISPR might fix the gene. But that's a long way off. What the ASOs are going to do, I'm hoping, for SCA3 is stop progression, stop the disease, and maybe for the surviving brain cells, there'll be some repair and they'll correct. So that's the realistic. Now, I love the second part of the question. What form will it take? Better vision, I have nystagmus, improved speech, improved balance, or all three? Well, that's where I mentioned earlier the part about if we use our special tools, our scientific tools, that say, oh, look, your brain has stopped, your cerebellum has stopped shrinking, or the neurochemical changes that Dr. Gluten O's studies have stopped happening, or your in coordination by my wearable sensors has stopped getting worse. We need your feedback to say, yes, and now my nystagmus is gone. We don't know yet. We want to eradicate all of those things. We want to eradicate the worsening. We want you to say, you know what, I was expecting to be in a wheelchair in 2 years and I didn't get into a wheelchair. We need those kinds of feedback. So we don't know the answers to that yet because we have not conducted these studies. And it is not as easy as COVID or no COVID. It's not as easy as that. It's a squishier result that we need help from the patient reports to give us the answer. But symptoms like nystagmus can be suppressed by vestibular medications, and so we can sometimes get some benefit. I have almost all my patients are on amitriptyline or gabapentin or 4-AP to try to suppress their nystagmus and their vertigo symptoms. Okay, let's see. With SCA types that exhibit anticipation, such as SCA3, it appears from studies that it tends to happen. Can you elaborate on whether it always happens and if there's any cases where a later onset symptoms than their parent? Oh, yes. And if the age of onset is always earlier, wouldn't it disease eradicated? Yeah, that's a great question. In other words, that's a fantastic question. The person's asking, if the repeat gets larger with each generation, won't the disease kind of die out? To some extent, that does happen. In horrible repeat expansion diseases where there's a big expansion, these poor patients of mine are definitely harmed so bad they can't have families. But in general, it's slower than that. And in general, sometimes they can get smaller, and the repeat size is not the final answer. Many of us have patients who have the same repeat size as someone else, and yet their disease is more severe or milder than that person, earlier onset. The best example I have is a couple of patients that I have in Washington State who are over 70 with almost no symptoms with SCA6. And another couple of patients in San Diego who have one smaller repeat than the people in Washington, and they have symptoms in their mid-30s. So it's not all the repeat size. Okay. Now it is quiet. Let me see if I can get out of this cold room.
Do you want to take some questions from the chat now?
Sure. That's good.
All right. Let me know when you're ready.
Yeah, they are, look like they're gone. So shoot.
All right. This attendee asks, I've been having cramps throughout my body. I have FCA3. Is that something that I should get?
Yes, SCA3 is one of the painful ataxias because of these cramps, and it's different people have it to different degrees. Surprisingly, it should respond to gabapentin or baclofen. So it's not so uncommon. I hope that that patient can get some benefit from either of those two medications. It's important to know how to use those medications. Remember, gabapentin has a range of doses. Some people benefit from a super low dose, and some people benefit from require 2,400 milligrams a day or more. So, and it has downsides because it causes a little bit of ataxia at higher doses. So we have to be careful. Okay, next question.
All right. Do those with ataxia eventually lose function of their legs and arms and ultimately become wheelchair bound?
Do those people with people with ataxia often become wheelchair bound? The amount of time to wheelchair is very different for different ataxia patients, and there's a difference between wheelchair bound and wheelchair smart. Okay, and same with walker bound and walker smart. I have patients who I encourage to get a walker sooner rather than later, just to be safe, and I have patients who I encourage to get a wheelchair sooner than later, but they aren't actually officially bound. I basically tell patients to get the full range of tools to have them cope and to use them invariably. For example, let's say you need a walker to get around the house and go around on the sidewalk outside, but your family comes to town, they want to take you to the mall with masks on, everybody's vaccinated, of course, and go to a park. You get in a wheelchair and you go faster that way, and then you say, okay, now I want to use my walker. So you be smart with your ataxia. But patients can often become wheelchair bound with ataxia. Yes.
All right. Do patients have to wait for an appointment at the Chicago Ataxia University Center?
Have to wait?
Right.
Well, they have to wait for an opening, sure. Of course.
And they're probably wondering what the kind of average wait time for an appointment is.
I don't know. I think it's only a matter of a couple of weeks. It's I'm not that popular, unquote.
This person asks, is SCA6 and EA2 the same thing?
No. The EA2 and SCA6 are caused, I love that question, are caused by mutations in the same gene. But patients with EA2 typically have really pronounced episodes where it comes and goes, and it almost completely disappears, and then it comes back again, and it's sometimes triggered. But over time, some of those EA2 patients, a lot of them will gradually have an SCA6-like progression. And the flip side of that is SCA6 patients have a mostly progressive disease, but sometimes, especially early on, they may have some pretty EA2-like similar episodes, and then they go away, and then they become more persistent. So they're kind of like two sides of a spectrum. And the mutations are different. And I think our research is trying to focus on explaining why different mutations can cause such different diseases and overlapping diseases. Okay, next question.
Are there any new treatments in diet or exercise that can help eliminate the onset of SCA or decrease symptoms?
There's a number of papers that have been published saying that structured exercise focused on coordination will definitely help improve coordination and improve the patient's coping with the disease. None of these, to our knowledge, are eradicating the disease or stopping the gene. We want to make that very strong point. And if you stop the exercise, in other words, if you go on a sort of a regimented exercise plan of walking and treadmill and stationary bike and coordination exercises and core strength for a few months, you'll notice a difference. And if you stop that saying, okay, all done, you'll go back to the same way you were before. Guess what that sounds very similar to, guys? Dieting. If you stop the diet, you gain the weight back. So it's just exactly the same thing.
Thank you for that. This attendee says, I was reading MIT Technology Review, and they mentioned an amazing drug molecule called Imrib. I was wondering if you've heard of it, and if so, what can you tell us about it?
I looked up the molecules that were in the questions, but I did not look up Imrib because I didn't know about it till now. Let me look at it. Let me look at, see if it means another name, you know, that I'm hope that it goes by a different name. Imrib. I don't even see it in Google. It isn't even in Google. Is it ISRIB?
Imrib.
No, it doesn't come up. I don't know what it is. But I want to make you guys smarter than the most famous person on the talk shows. Okay. If you see a drug that's amazing for something, doesn't mean it's amazing for ataxia. Okay. And there are people out there who think that if ivermectin is amazing to get worms to kill various types of worms in humans or in horses, and it cures people of horrible worm infestations, that's going to work for COVID. That's not true. Just because something works for a worm infection in your liver, it's not going to work for COVID. Medications are smart. They're targeted at specific things. They just don't work randomly. So the COVID vaccine is the best example of that. It directly induces an immunity against COVID. Okay. And the ASOs are like COVID. The ASOs are going to directly silence either Huntington or Ataxin-1 or Ataxin-2 because they're directed to a specific sequence in those bad genes to silence them.
That's a really good way to understand that. So our next question is a CPAP or BiPAP machine helpful for SCA patients?
Oh, I think that's a great question. I mean, you have to start by finding out whether the patient has obstructive sleep apnea. If they have obstructive sleep apnea, whether they have ataxia or no ataxia, a CPAP machine is very valuable because what's happening in obstructive sleep apnea is you are losing oxygen at night. Your oxygen concentration is going down in your body and maybe your brain. And when you have reduced oxygen, things get worse. So there's actual nerve damage. So you use CPAP will help prevent that. As inconvenient as that machine, as that mask is, it will help prevent the episodes of loss of oxygen, which just makes matters worse for ataxia.
Right. What are your thoughts on Rife Technology, R-I-F-E?
I never heard of Rife Technology.
All right.
Let me just look, Lori, let me look that one up quickly to make sure I don't screw up, and I might be able to find it. Rife Technology. Rife Technology. This says it's a machine. Rife machine works for cancer. There we are again. We don't want to treat worms. We want to treat, and we don't want to treat cancer. I mean, we do, but if we have ataxia, we want to treat ataxia. So it says it's used for cancer. So these are things that you guys, you want to pay attention to the science, not to the internet, not to, I had a daughter of a patient just an hour ago telling me she didn't want to take the vaccine because she's seen information on TikTok that the vaccine for COVID is bad. TikTok, are you going to affect your life based on a TikTok video? No. She told me she read some articles also, and she's sending those to me. But the point is, you want to use science. That's why you're talking to me. And you talk to Jeremy, and you talk to Susan Perlman, and all the scientists who study ataxia.
Exactly. Great advice. So we have an attendee here in Sweden, joining us from Sweden.
Oh, nice.
They have a 4 and a 5-year-old, both suspected with ataxia. The specific type, though, has not been defined. The biggest symptom right now is constant shaking and weak lungs, often susceptible to pneumonia. Extensive tests confirmed a failed gene in both children. However, this gene and its associated function is not yet known. Both boys struggle with low albumin levels and low TAO protein. As we cannot define the type of ataxia here, have you any recommendations on where we might try to get a correct diagnosis?
Yes. I mean, if I can't tell for sure if she knows a whole exome sequencing has been done, but it sounds to me the closest similarity would be ataxia telangiectasia, which can cause lung problems and ataxia in that age group. But I don't know what the tau protein, how that was measured. That's something can be abnormal for a lot of reasons. If exome sequencing has been done, then those results need to be looked at by some specialists in ataxia. Right south of them in Germany, there's a lot of really, really good ataxia experts who could look at those results and decide.
Great. This attendee wants to know what, in your opinion, is the future for a cure or treatment for SCA3?
Well, those are related to a bunch of the questions we've been answering before.
Mm-hmm.
I believe that the excitement on the horizon are the ASOs well, there's two actually. The chaperone protein strategies that sort of help to unfold proteins or fold them better is one strategy which is being looked at, and the other is the ASO strategy. Both of those, I think, are very, very encouraging in models, in preclinical models. Those would mean cells or in mice, in which you can silence the protein, silence the gene, eliminate the protein, and improve the behavior of the mouse or the function of the brain. And those are, I think, very exciting. And I think that we're going to have trials for those within the next 2 years for SCA3 therapies. The goal is next 2 to 3 years trials of multiple types for SCA3. It's logical they would target that one first because it's the most common globally.
That is really exciting.
Yeah.
All right. So another question is there a type of ataxia that the onset is birth? If not, any ataxias that you know of that the onset is around 2.5 years old?
Yeah, sure. I mean, there's lots of ataxias that are congenital. A whole family of them that are involving developmental genes. So it's easy to say yes without naming any specific ones. There are, what was the second question? Are there 2 and 3 year olds?
Yep, birth or 2.5.
Yeah, so a lot of the recessive ataxias occur at those ages, the majority of them. So it depends on the type of mutation, but you could see this rarely in Friedreich's. Friedreich's is a little bit later in onset, but lots of like SPG7 could that be that early? Ataxia telangiectasia could be that early. AOA, ataxia with oculomotor apraxia types 1 or 2. A number of these recessively inherited ataxias where the parents are only carriers and the patients get 2 carrier genes could manifest symptoms that early.
So another question is the OT vest, weighted deep pressure vest for the trunk stabilization. Can that improve balance?
So they say. In other words, this is a patient-reported outcome. And so there's a situation where an intervention, a therapy, has already had a set of responses from patients that are thumbs up. It would be great for us to have the bandwidth to test that with an objective measure as well, and have those two things collaborate and coordinate. That's something that's on our list of things to do, but we have to sort of prove our measurement, our sensor measurement a little better before we can do something like that.
Another question is epilepsy linked to SCAR20?
I was just reading a couple of Mike. Can you ask Mike Geshman's question in a little bit as well? But or maybe he's answering questions. Sorry. So what was the thing you were just talking about? SCAR20?
Yep. The question is epilepsy linked to SCAR20?
Well, I don't have my SCARs all figured out here. Let me just look that one up. See if I know what the other name for it is.
The attendee goes on to say, to ask, can seizures appear every 2.5 months and last for 24 to 26 hours and then disappear?
Hold on, let me just see. So SCAR20 does not have a gene as far as I can tell. Here, see. Hang on. Oh yeah, it has mutations in SNX14 gene. So I'm sure that this is a rare enough gene. I don't know how common epilepsy is in that, and I don't know enough this gene well enough to know about seizures in that. The next question is, how long can seizures last?
Mm-hmm.
Seizures can last for a long time. It's very harmful. You need to be stopped with medications, but focal seizures can go on for an extremely long time, days.
Wow. Well, thank you for answering that question. Here's another question. And I know that you mentioned the COVID vaccine a few times. So this question is the COVID booster recommended for ataxia patients?
Let me just, I meant to ask this the very first time. I hope that everybody on this call is vaccinated against COVID. I sincerely hope that. It's very important to stop this pandemic before it consumes, the flames can consume our country. Okay, so having said that, the booster has not yet been recommended for the condition of ataxia, unless people are over 65 years of age. But if my word is of any use, I'd be happy to say that and let them come and get me if that were be something, meaning that the authorities, if that would be a misstatement. There's a lot of wobble in that answer. I went ahead and got the vaccine, the booster ahead of its authorization, because I was going to be traveling a long way away, and things are slowly sorting out. But the problem is, poor FDA and CDC have a hard time keeping up with the moving target of information and the pressures of the outside. But eventually, I'm hoping we prove that boosters are valuable for everybody, and people get them as soon as we can.
That's great advice. Thank you. Can you speak to the subject of gluten medicated ataxia?
I don't understand the second part of gluten medicated ataxia.
Oh, gluten mediated. Sorry.
Oh, okay. Yeah. I don't believe in it, actually. I believe that if gluten caused ataxia, it's caused it by causing you to malabsorb vitamins A and E to the extent where vitamin A and E deficiency cause severe damage to the nervous system. I think gluten itself, I question whether it can cause ataxia, and that has something to do with some research that a colleague of mine, Kalaf Bouchard, did a number of years, where he showed that patients with SCA2 get an artifact of gluten antibodies as a false positive. So I question the validity of gluten ataxia. I've never seen it in my 30 years of practice.
This attendee says that they were genetically tested and found to have both SCA15 and 29, as well as CMT2T. How rare is that SCA combination? And is there anything on the horizon to help?
If it's true that they have those types of ataxia, it's extremely rare, and CMT. Remember, a lot of those exome sequencing results need to be looked at very closely because sometimes the exome sequencing results just report a varied of uncertain significance, and different labs have different levels of calling the importance of those findings. So they need to be looked at very carefully. SCA15 is predominantly a disease of deleting a gene. And what was the other one that they had besides SCA15?
29
Yeah.
as well as CMT2.
So 29 and 15 are the same gene. So that's not really two different genes, it's the same gene.
Well, then I can see how that would.
Yeah, so they really don't have two ataxias. I think that's the one that's overlapping.
Gotcha.
Yeah. So the CMT, it's a complicated one. So but it's possible. I have a handful of patients who have two ataxia genes, and we can't discern which of both is causing the predominant symptoms.
Gotcha. This attendee is asking, what would you recommend for a 70-year-old strong man who's been diagnosed with idiopathic ataxia and signed off by the doctor without therapy or more investigation? How can you get them to dig in and refer him to a specialist in the area? Can he get gene testing? They have confirmed that he has not had a stroke. Is there vestibular medication that he should try?
There's a lot of questions. Genetic, I mean, an 80-year-old strong man could still have a genetic ataxia, or it could be an undefinable sporadic ataxia that we haven't found out the cause of yet. It doesn't feel to me like it's multiple systems atrophy because he's out of a different age range. And I guess we need more clarification about what the natural presentation of his disease is. Is it vestibular? Is it cerebellar? Is it sensory ataxia? And the investigations would change at different times. And what was the last question about a medication you asked? The vertigo? Yeah,
vestibular medication. What vestibular medication should
it's hard to know just talking on a Zoom meeting, which I would try. I think my most common go-to, because it's so benign, is amitriptyline, but he's on the old side for using amitriptyline as a go-to. I guess I might try meclizine first. It depends on what his true vestibular symptoms are.
All right, so we'll just do one or two more questions. I know we're running out of time here today. This attendee's question is, her 44-year-old brother is an ataxia patient. He's now bedridden. Can you offer any guidance on how she should treat him, how she can let him do his own works, or what are the different ways to make him balance his body?
Well, he's bedridden. He's not going to balance his body anymore. Is that right? I would recommend supportive care, range of motion exercises. Make sure he doesn't get bed sores. And enable him to have, maybe if he is able to do this, can he have a recliner or reclining exercise plan where he has some sort of a stationary bike, recliner bike, or something like that for him to be safely exercising, and physical therapy in his bed. It's hard to know what his severity truly is.
Right. This attendee has SCAR10. Should she be concerned that her daughter might have it?
No, without even knowing what SCAR10 is, I'm quickly looking up because the names are changing rapidly. If the R in that name at least tells us the following, it tells us that it's recessively inherited. So the chance of a recessively inherited disease being passed on to a child is extremely low, and it's influenced only by the frequency of that gene and whether the patient, whether the other parent has that gene. It would be extremely rare. Even the commoner ones like Friedreich's, patients with Friedreich's don't pass on to their children. If you really wanted to know, they would have to test the other parent to see if that patient has an SCAR10 gene. It's highly unlikely.
All right, next question is a hyperbaric chamber ever useful for ataxia?
I don't know. I don't know much about that approach.
And do you have any thoughts about HSP?
Heat shock protein, the thing which is modified in hyperbaric oxygen. I'm being snarky. Or
Hereditary spastic. Yes, that one.
Okay. So some of these, SPG7, for example, is an HSP. Most of the HSPs are non-ataxia causing, just a small number. Famously, SPG7 is the one HSP which causes a lot of ataxia, but most of them don't. They cause a gait disorder, like SPG4, like HSP4 and HSP5, that cause a gait disorder. Or sorry, SPG4 and 8 that cause a spastic gait disorder.
All right. Well, I think that is all we have time for today.
It makes me sad because there are so many other good questions on this list that I couldn't answer.
Well, we'll have to have you back for a future session.
And plus all the chat ones, I've noticed that chats go away.
Yes.
They're not saved.
Yes.
Which is tragic.
Yeah, I do.
I want to just answer one. Can I just answer one myself?
Absolutely.
Adelia Gasanova asked one, which was at the SAMDL gene, is it related to ataxia? Yes, the SAMDL gene, because I have some patients with this, can develop ataxia as well as this blood cell problem, deficiency in platelets, et cetera. That was a new one to me, just discovered, I think, in 2013. There's a lot of questions here. I'm so sad. If you guys feel like saving those questions and putting them into a list for Lori, I think that a lot of ataxia guys, I mean, Mike Geschman's on the call, which is fantastic. He should do one of these as well. We need to get these questions answered, even if they're sort of a collection of questions on NAF's website.
We'll do our best to copy and paste as many of these chat questions and document those.
Yeah. Rick, email me. Rick Remke, email me if you have a question. I didn't get a chance to answer it. Thanks, you guys. It was really nice to answer all these questions for you guys.
Well, thank you so much, Dr. Gomez. And thank you everyone for joining us today.
Thank you for all your work.
Oh, Larry's on the call too.
Yes.
Hi, old partner. How are you?
Hey, buddy. How you doing?
Good. Say, would you email your phone number? So I have a large family with SCA6.
Thank you. Thank you very much. I will definitely send it to you. What's your email address? You could have Lori.
Lori, do you have my?
Lori,
I will share that with Dr. Gomez. You bet, Larry.
And whatever Larry Scott eats and whatever church he goes to, I think you should follow him because he's pretty old and he's really, really intact. He's got a great brain. You should follow Larry Scott's diet.
Absolutely. All right. Well, thank you so much, Dr. Gomez.
Take care, everybody.
You certainly covered a lot of information.
Stay well. Get vaccinated if you have not.
Absolutely. That's great advice. There'll be a recording of today's session for everyone to reference. And we hope to see everyone at next month's expert session and this Saturday at our virtual walk and roll. So until then, take care, everyone.
Bye, guys.
Bye.
Bye. Thank you.
Bye.
Thank you.
Thanks, Lori.
Bye.
Bye.
Thanks, Lori.
You're welcome.
Thank you so much.
You're welcome.
Thank you.
You're welcome. Take care, everyone.
Goodbye.